I would like to talk to you about what the implications of family history means for breast cancer. I tried to prepare my speech or presentation in both in English and Korean, and some parts of them are in both languages. If I have breast cancer, is my daughter going to be okay? What are the odds of my daughter getting a breast cancer? A lot of women, when they are struck with breast cancer, are concerned and worried about their daughters. If the mother has breast cancer, her daughter is at increased risk of developing breast cancer compared to the other remaining population, general population. And when mothers, daughters, and sisters, in other words, the first-degree relatives, diagnose breast cancer before the age of 50, the risk of developing breast cancer is twice that of women without prior family history, exactly twofold. So if you look at the phrase, the sentence, it's the number of relatives with breast cancer and the age at which breast cancer was diagnosed in those relatives. Depending on these two factors, the risk level will be different. So we have a first degree, second degree, and third degree relatives. First degree refers to parents, offspring, and siblings. So it's parents, brothers and sisters, and your daughters. Second degree include individuals, grandparents, grandchildren, uncle, aunts, and nephews and nieces. The third degree refers to great-grandparents and children. So if you have one family member in the first-degree relatives, the risk for breast cancer will be 24%. Two members of the family in the first degree, 36%. One member of the family in the second-degree relative scope, 22 degrees, etc. So depending on the number of family members that have breast cancer, this is the risk level. When you have one relative with breast cancer, the risk ratio is 1. When none of them has breast cancer, the risk level is 1. If you have one family member, it's 1.8. If you have two, the level of risk is 2.93. So depending on the age of diagnosis, as you age, the risk level goes down inversely. And my age is also important. If I'm in my 30s, 40s, 50s, and 60s as I age, the risk level will go down. In other words, it's more risky for a young woman to have breast cancer because that means that the other family members can also be affected by breast cancer. So when there are two family members of a first degree, and if I am before the age of 50 and after the age of 50, if any of them had breast cancer before the age of 40, the risk is 13.5. The risk ratio after 50, it's 3.9. If two of them were diagnosed after the age of 40, the risk ratio is 7.8 before the age of 50, my age before the age of 50, and 2.6 after my age of 50. And so this is parity. And menopause at a relatively younger age, the risk goes down. And use of contraceptives, it will elevate the risk a little bit. And use of hormone replacement therapy, a little elevation. So along with these risk factors, as important when you consider the risk of family history. And also, this is based on the U.S. If the risk of this person getting breast cancer before the age of 80, if no member was affected by breast cancer, if there is no relative, the risk is 7.8. The incidence is 7.8. One relative, the incidence 13.3. And if there are two relatives affected by breast cancer, the incidence rate is 21.1%. The probability that women who are free from breast cancer at age 20 will develop the disease or die from it by various ages, according to the number of affected relatives. I would like to talk to you from now about hereditary breast cancer. What type of cancer is this? Angelina effect, or Angelina Jolie is a well-renowned star. She was in her early 30s, and in 2013, she she has written an article in the Time magazine entitled "My Medical Choice." She married this handsome star and then divorced. So she has her own children and adoptive children. Her mother dies at the age of 56 of ovarian cancer, but before that she had breast cancer. Her aunt dies at the age of 61 by breast cancer, but Angelina Jolie was not affected by breast cancer nor by ovarian cancer at that age. But her mother was only able to see her first child. So in other words, the remaining children were unable to meet or know her mother. So she wanted to find a way to overcome this. So this is not her family tree, but this is a family tree that has a similar BRCA gene mutation. And we can see that different members are affected at different age levels. So in the case of Angelina Jolie, she had BRCA gene mutation, and she had an 87% risk of developing breast cancer and 50% risk of developing ovarian cancer.
암에 걸리지
She wanted to be more proactive, so she decided to get a double mastectomy. And afterwards, she is planning to have an oophorectomy. And so she went through genetic testing, and based on the results, she has decided to opt for a strong preventive choice, and she wanted to disseminate this to others. So she was very courageous and brave in doing this, and and also writing this article in the Time magazine. And so in the case of people with these family or hereditary breast cancer, we would like to know what the risk or risk factors are associated with. So we talked about estrogen, aging, radiation, lifestyle, environment, among others, since this morning. The strongest factor is genetic factors. So we have the hereditary cancer that make up 5 to 10% of breast cancers. Mutated phenotype of a specific gene segregating with a Mendelian inheritance pattern in families. So apart from this, we have a familial cancer with one or more first and second degree relatives of the proband affected by breast cancer in the absence of Mendelian inheritance that make up approximately 1/5 of the total breast cancer population, and we have a sporadic. And we have other factors that come into play, but they are insignificant. For instance, TP53, that's less than 1. And we took a closer look at what level of risk these factors represent. And this gene mutation, very frequent, but the relative risk, the risk was only 1.5 points higher. So these people just have to go through regular breast screening. But on top, we have a less frequently expressed gene mutation. But for those group, we need a more active and proactive screening, sometimes inclusive of MRI, and also sometimes risk-reducing surgery. If you look at BRCA2, BRCA1 has to do with chromosome 7, whereas gene 2 has to do with chromosome 13. They were discovered respectively at 1994 and 1995. And the gene, the DNA repair becomes defective. Because of this gene mutation, the errors will be repeatedly accumulated, and it will lead to defective DNA repair. And so this would lead to cancer. And this has to do with chromosome 13 and 17, but this are not sex chromosomes. They are chromosomes that's common to males and females, so it can be hereditary from father to son. And so this defective gene, the siblings will get one from the father, one from the mother. So the children all have a 50% risk of inheriting this deficiency. So if the parent is tested to have this gene mutation, the children must go through a gene test. So why is that so? Because the breast cancer has two defective genes, so it takes a long time. But if you already have one gene that's defective, so when there is a very abundant estrogen in your body, that mutation will happen very readily within that environment. So even before your 20s, 30s, 40s, cancer can be expressed, and especially in the U.S., hereditary breast cancer can be very frequent in the United States in the population aged more than 70 if you have a family member that has had breast cancer in a younger age. So this is the BRCA1 gene mutation. 30% of them had breast cancer. In the BRCA2, 10%. But BRCA1, before the age of 50, the incidence goes up and it goes down afterwards. BRCA2, as you can see, after 50, even after the age of 50, it still goes up. So at the age of 80, they both reach 70%. And what does this mean? Depending on whether it's BRCA1 or BRCA2, this means that you are susceptible to more to one of these cancers. So in other words, Angelina thought that she was more susceptible to breast cancer at that age. And for ovarian cancer, this BRCA elevates the risk of ovarian cancer, but BRCA1 would elevate the risk from your early 30s, whereas BRCA2 would intervene at a later age. So when you're in your 30s and your 40s, you're not done yet with childbearing, so it can be problematic to go through a salpingo oophorectomy. So for people who already had a first breast cancer and is a carrier of this mutation, 40% of them would have a second breast cancer down the road. So it's very important to monitor this population. So we looked at the Korean population, the Korean hereditary breast cancer, the COBRA study from 2010. And in the case of, we looked at the prevalence of BRCA mutation of those breast cancer patients. If my mother or my sister had breast cancer, we followed them, and approximately 25%, or in other words, 1/4 of them had a BRCA mutation, which matches the Western data. So in other words, we know that there is a prevalence and the risk level that's similar to the Western population. We said that the age is an important factor, the age at diagnosis. As the age gets younger, the risk goes up. So you will have to think of this hereditary breast cancer. And when you have young age, you have a bilateral breast cancer. And if the same person has breast and ovarian cancer at the same time and male breast cancer, all of these are also related to this. So this, the result of this test or this study led to this fact. It's a very expensive test. This gene test would cost about 800,000 won. And so we gained national insurance reimbursement as a result of the findings of this study. So if the probability of having genetic mutation is more than 10%, you would go towards genetic counseling. If it's more than 20%, you would go for risk-reducing management. So what case is this? When you have a BRCA1 or 2 mutation, which is 70 to 80%, and there are other genetic variants as well. And all of these come together into play. And they intervene in the process of DNA repair, and that can lead to a more prone environment for breast cancer. If you don't have a genetic variant or a gene mutation, or if you don't know your mutation status, but if you have a strong family history of breast and ovary cancer, these people make up 20% or more. So these people should be managed as if they had a hereditary cancer. aggressive but better prevention, how to manage them. Options for BRCA mutation carriers. So this is the determining factors of BRCA mutation carriers. You will have to modify your lifestyle. This was repeatedly underlined. And also, you will have to actively do surveillance for cancer, breast cancer, and ovarian cancer, and chemo prevention option, and risk-reducing surgery like Angelina Jolie. And also, I would like to now talk about the benefits of such approach. You have to avoid extra estrogen exposure, parity, breastfeeding, avoid alcohol drinking, avoid obesity, avoid radiation, and do physical exercises. So these are principles that will reduce the risk of breast cancer in any population. So if you are a BRCA carrier, usually you will have to begin your screening at an earlier age, at the age of 18. Usually, we would recommend a self-examination at the age of from the age of 25, but in that population, at the age of 18. For those BRCA, known BRCA gene carriers, you will have to start screening, medical screening, at the age of 25 years old, breast screening through MRI screening. But it's difficult to execute this in some countries because MRI screening is expensive. From age 30, annual mammogram plus MRI. In Korea, the national cancer screening program begins at the age of 40, but this is earlier than that, and after that, we can think of a risk-reducing surgery, such as risk-reducing mastectomy or oophorectomy. I will come back to this. For ovarian cancer, every 6 months, you will have to check for your serum biomarkers, like CA-125. But this is not really efficacious. When you are diagnosed with ovarian cancer, you're usually stages 3 or 4. So this CA-125 elevation is effective in only 50% of the cancer population. So maybe self-oophorectomy at a younger age can be an option. But if you can't afford that, maybe this is a second best option. And the second is chemo prevention, tamoxifen administration, which reduces risk of breast cancer in non-breast cancer diagnosed patients. And for those patients with first breast cancer, would reduce the risk of contralateral breast cancer. And oral contraceptives can reduce the risk of ovarian cancer, but on the contrary, it increases the risk of breast cancer. And now the risk-reducing mastectomy. Bilateral mastectomy, you would leave the nipple and the areola. And the nipple sparing mastectomy would reduce your breast cancer risk by 90 to 95%. The cancer can recur and can happen in the remaining areas. But we have an MRI, a very strong diagnostic tool. The survival rate is similar in those two groups, in the mastectomy and the MRI group. But the difference being that you don't have to go through the painful process of having a breast cancer. So in the contralateral breast removal and reconstruction, this is something that is also reimbursed by the Korean National Insurance Program. In the case of RSO, it usually is performed between the ages of 35 to 40 after childbearing is complete. If you do this, you will be able to reduce ovarian cancer reduction by 80 to 85%. But if you do an self-oophorectomy, it also has the effect of preventing breast cancer risk and contralateral breast cancer risk. It is reduced in 50%. So it has a clear overall survival benefit because of this. And also, the surgery is done using laparoscopy, and so you can go back home the following day. And so it has a very big benefit in that population. So how big is the benefit going to be? So in people who have no cancer, the number of cancer reduced from 6% to 2%. In breast cancer patients, if you conduct an RRSO, it goes down to 4% from 16%. So if this mortality rate can be reduced so much, this is rarely seen in other types of approaches. And after mastectomy, you will see usual complications after surgery and after general anesthesia. So there needs to have you need to have an extensive discussion with these candidates because some of them would regret their choice, but most of them are liberated from the fear of getting cancer. So most of them are very satisfied after opting for such choices. In the case of RSO, can have symptoms related to early menopause. So Professor Kim has given you some tips. But in any case, if you have a gene mutation but you don't have breast cancer and have gone through RSO in your 30s, you can opt for a short-term HRT without increasing the risk for cancer. And coming back to our family history. So are you going to do a genetic testing or not? After genetic testing and counseling, it all begins with family history, taking family history. Detailed family history is very, very helpful. So family other than mother is also important. 3 generations up and 3 generations down. You don't know what each of these family members had. So if you want intensive counseling, you will have to take a closer look at what your family members had. And what I want to emphasize is the mortality risk, the recurrence risk, the risk for cancer, all of them is something that's known only after you are diagnosed with such diseases or conditions. But family history is something that you can probe for beforehand. So parents, offsprings, and siblings. By testing these first-degree relatives, you will be helpful in preventing these risks and come up with a customized management according to individual risk.